I'm Eric Marks. I'm the Associate Dean for Faculty Affairs here at the university, and I'm in the Department of Medicine and in the section of Medical Jurisprudence. And as the moderator of the first panel, I have the pleasure of doing some of the business items that we didn't do out at the desk. 3 to be exact, starting with the most important, and that's lunch. We have 45... Can you hear me in the back? Then the microphones are not on. I'll start again. Let's speak about lunch. Can you hear me now? Okay. Lunch is going to be for 45 minutes, and your pass to eat here is your name tag, and as soon as the last session is over prior to lunch, lunch is going to be a sit-down lunch served in the cafeteria and in the executive ballroom, so if you would just move off to the left when you leave, we'll try to do that expeditiously so that we can stay on schedule. Second of all, after each one of the presentations, there'll be a question and answer session. Should you so desire not to go directly to the microphone but send up your material, there are colored cards within your folder if you would like to fill those out during the session. Somebody will come by to collect them and come up to the front. And then the last comment that I would make is that in your syllabus there are a number of papers. These papers were selected on the basis of interest. They were not necessarily selected by the speakers for the individual topics and therefore do not necessarily represent their particular opinions on that topic, but were selected to be representative. With that aside, let me then state that we've decided to initiate the conference with a discussion of something which is extremely basic in terms of human use research, and that is the concept of what is risk. And although we have entitled the first session on what constitute minimal risk, the way the presentation will follow is that there'll be a discussion of an overview of risk in general and then a more clarifying discussion in terms of minimal risk. And we're extremely fortunate to have with us 2 very highly qualified individuals to have this discussion. The first, Dr. Allison Wickman, who was the past chief of the bioethics program at the Clinical Center and now is the current deputy director of the Human Subjects Research Group at the NIH. And we have Dr. Charles R. McCarthy, who at present is a senior research fellow at the Kennedy Institute of Ethics, but as you can tell by his bibliography within the program, has had a very distinguished history in this particular area and was a past director of OPRR for 14 years. And as I commented to the speakers, you came to hear them converse and not an introduction by me. So the first speaker will be Dr. McCarthy to give a historical overview of risk and some of the guidelines that are presently in place, and that will be followed by a more focused discussion on minimal risk by Dr. Wickman.
Thank you, Dr. Marks. I'm just back from England where I caught a cold, and I'll return to that topic in a moment. But first, I want to thank especially Dr. Ruth Bolger and Sergeant Scales. Sergeant Scales tracked me all over the globe in order to arrange for my being here today, and she clearly performed above and beyond what might be expected of an organizer of a conference like this. My topic is one that is highly controversial and very difficult, the whole concept of risk. It's very easy to deal with risk when we deal with it in the abstract. Everyone knows, and the regulations cite very clearly, that risk is a combination of 2 things: the probability of harm or discomfort and the magnitude of that harm or discomfort. 2 very different concepts, and yet they get folded into one under the notion of risk. And so a risk can be very high because the magnitude of harm that can occur is very great, even though the probability is low. A risk can be very high because the probability of harm is great, even though the magnitude may not be quite as severe. Clearly there is no mathematical, there is no formula that can be applied to risk. This has to be a very human judgment. And that takes me back to my recent trip to to England. And I want to simply spell out the difference in perception of risk between one person and another. I started my trip not in England but in Scotland and stayed in a bed and breakfast. And as it turned out, I shared a table with an Air Force captain who was stationed in England. He was on a week's leave. And we talked about the things we were going to do in sightseeing and so on. I told him I was going to rent a car, drive down and spend several days in Cambridge. The captain told me a little bit about himself. He's been stationed in England a little over a year. He is head of an air unit. He flies F-16s. And then he said to me, if I were you, I wouldn't risk driving in England. Here is somebody who flies F-16s, and even though he seemed very competent, there's no way he could get me into an F-16. From my perspective, the risk would be far too high. Even though he is extraordinarily well trained and competent to handle that machine, I want no part of it. He took those risks for granted and considered them very low. But he considered an American trained to drive on the right side of the road, driving in England in unfamiliar territory on the left side of the road, especially an elder American. And he was very discreet about pointing out that my reflexes are not as great or as quick as his. And he felt that the risks were overwhelmingly against my making it to London. That will give you some idea. The magnitude of the risk, we agreed, could be very great if we had something like a head-on collision. Namely, if I attempted to drive down the right side of the road and met British traffic coming in the opposite direction on that side of the road. My wife and I immediately retreated to our room and had a long conference about risks. We decided to rent the car, and I'm here to show you that our assessment of the risk, at least in this case, turned out to be the correct one. I had actually been in England or Ireland many times, had a record of having driven close to 10,000 miles on the left side of the road. He didn't know all that, and therefore was reasonably comfortable with the British system. I also note that the British are far more courteous in their driving than Americans, and the highest risk I've faced recently is coming up Route 95 from Richmond, not driving from Edinburgh to London. But it gives you a perspective that risks look differently from different perspectives. And that is why we have IRBs, because clearly a research investigator thoroughly familiar with his or her field, thoroughly familiar with the procedures that will be involved in the research, treating that as common everyday business of the researcher. Clearly, that individual is going to have a different perception of both the magnitude and the probability of risk than someone who is less familiar, and certainly is going to have a different perception of risk than a research subject who may lack the scientific understanding even to understand the risks, and therefore is driven in many cases to trust the integrity of the research investigator, who almost invariably inflates the benefits and almost invariably reduces or minimizes the risks that others see in the research project. And this is a reason why. These are honest people. It is simply that when they speak from their perspective, it is a perspective very different from the rest of us. And consequently, it is necessary to have some sort of independent judgment about risk. In recent years, it has seemed to me as I've visited IRBs around the country, and particularly since I retired from OPRR and research IRB chairpersons are willing to speak to me a little more frankly than they did when I was in a regulatory role. They tell me that their IRBs spend enormous amounts of time dealing with informed consent, but they pass over very quickly the very difficult, onerous, and somewhat subjective dimension of assessing or evaluating the risk associated with the research project. The regulations require them to do so. Some IRBs feel that is paternalistic. They say, as long as we can get the consent of the subject and tell the subject what the risks are, then we don't have to worry very much about our own risk assessment. That is wrong. We must recognize that for most minimal kinds of risks, the reason they are minimal is that the subject himself or herself is familiar with the risk involved. But when we're dealing with more than minimal risk, in most cases, the subject is not able to assess the risk and therefore needs the assistance of the IRB to make a dispassionate, objective assessment of risk so far as that is humanly possible. And that's the main point I want to leave with you today, that each research subject depends on the IRB not only for a good consent process, but depends on the IRB to do a careful, responsible assessment of the risks and to explain those risks in layperson's terms so that the subject himself, herself can assess those risks and make an honest judgment as to whether to participate in the research. That becomes all the more difficult in the military context, where obedience and following orders is the environment in which research subjects tend to live. And therefore, to say, your judgment in this case is binding, runs contrary to the entire environment in which most military personnel live. And therefore, we must work very hard to create a setting in which the subject, one, can understand the risks, and two, understand the freedom to assess those risks and to say no, and understand there will be no penalty or repercussions of any kind if that individual elects not to take that risk. The Air Force captain that I talked about would not have driven my rental car. I would not have ridden in his airplane. But if his commanding officer said, would you like to volunteer to drive a rental car, I dare say he would have said, yes, sir. So we need to create an environment in which risks that an individual would elect not to take can be properly assessed, and a climate of freedom whereby the individual can say no. Very difficult in a military context. It takes great perspicacity. It takes the opportunity for those conducting the research to realize that there is a subjective dimension to risk, and for someone not to take an optional risk is in no way a negative kind of evaluation of that person's valor. Now, the regulations, and Dr. Wickman is going to talk about this, set many places where minimal risk is a criterion for making a judgment about expedited review, about exempt research, about certain kinds of waiver of informed consent and the like. And she will explain that, and she's expert in doing that. What I want to suggest is that in the drafting of the regulations, there is a statement about what minimal risk means, and that statement says, in the daily lives of subjects, consistent with routine physical or psychological examinations. That's very, very difficult to apply in a military context. What is a routine psychological examination for an Air Force pilot may be very different from a routine psychological examination for someone in the infantry. And consequently, we need to look at the context in which the research is to be carried out and the particular subjects who are to be involved, and to see what might constitute risk from their perspective. This doesn't talk about the daily lives of normal, healthy individuals. It talks about daily life, and the implication is that the daily life is the daily life of the subjects who will be involved, not the daily life of some abstract individual that does not actually exist. And so the IRB once again has the additional responsibility of looking at these particular subjects and their ability to undertake and to assimilate the kinds of harms or discomfort that may be associated with the research. It seems to me that IRBs tend to look at the protocol and assess the risk without very much reference to the subjects who will be involved. And that can be very different when one looks from one subject to another. The difference between a normal volunteer and a sick person is extraordinarily important. Both may volunteer as subjects or are free to refuse to be subjects, but their situation and their autonomy is very different in the two situations. If you couple that with the military environment I've already talked about, then it becomes a much more difficult decision. And that's why your military IRBs perhaps have the most difficult job of any IRBs in the country, and we all know that every IRB faces a difficult set of decisions. How do you go about this? You first look to your own experience. Do you have any experience in your life that corresponds to the experience of the subjects likely to be involved in the research? If you do not, it is very important to interview typical or representative subjects who can tell you how the risks look from their point of view, because there is a highly subjective dimension. You may have statistics of failure or success, but what is more important is how this looks to the subject. Let me give you an example. My sister recently developed a case of breast cancer. She was placed on a protocol, read through all of the risks associated with the protocol, and the drugs, the chemotherapy that was offered to her included dangers to her heart, to her liver, to her kidneys. Some of these, so it said in the consent document, might be irreversible. Not certainly irreversible, but possibly. Also listed was swelling of the tongue, soreness of the mouth, and loss of hair. When I spoke to her afterwards, I said, "Which of the risks struck you as the most serious?" And she said, "Loss of hair, of course." Even though the return of her hair was promised after the course of chemotherapy. All of the other risks that I considered far more major were bypassed by her. She was in a kind of state of denial about those, but the one thing that really bothered her was that her public appearance would be altered for a considerable period of time. Was her assessment of risk or mine the one that should govern? In actual fact, I think the IRB needs to take into consideration both perspectives, the perspective of the subject who may focus on relatively objectively minor risks but important to that subject, and emphasize those as much as the more serious physical kinds of changes that are associated with chemotherapy or with research of that kind. So what I'm suggesting to you is that you act in a very judicial way, that you find out how the risks look to the prospective subjects and make your risk assessment according to the kind of subject that you expect to be enrolled in the study, and then move ahead to make sure that those subjects understand those risks, freely accept them, and participate in the research. These are general kinds of comments. They don't say very much about the regulatory side of research. What they say is that despite all the regulations governing and guiding IRBs, we still need competent, we still need we still need careful IRBs to assess risks both objectively, subjectively, and to make judicial decisions. There is no formula that can replace the human being, the compassionate human being, to make those kinds of judgments. Whether we're talking about minimal risk or whether we're talking about larger risks, the IRB must be extraordinarily careful. It must recognize it is representing the subject in making important decisions, and it must take its risk assessment seriously. Dr. Wickman now is going to talk about minimal risk and its role in this whole context. Thank you very much.
I don't think this is on. Is this on? Okay. Well, thank you, Dr. McCarthy and Dr. Marks. I have also just been in Ireland, and I would disagree with Dr. McCarthy. I would much rather ride in an F-16 than drive on the left side of the road. In fact, I have always wanted to be in an F-16, and so I would welcome that opportunity. Dr. McCarthy's given you an overview of risk in general, and what I'm going to talk a little bit about more is the definition and application of minimal risk. And what this minimal risk represents is a risk threshold criteria that is very pivotal in the protection of human subjects, because once a research study or a research activity is found to represent minimal risk to subjects, there are several things that can happen. First, the protection of a full IRB review and approval may be changed. That is, there are other ways to review research that has been designated minimal risk, and I'll briefly discuss that. And also, the protection afforded by full informed consent in some cases may also be waived or altered. And so this risk threshold criteria of minimal risk has major implications in protections afforded to prospective research subjects. Well, the reason for the minimal risk definition, and Dr. McCarthy didn't mention this, but he was very much involved in the drafting committee that came up with the definition. But basically the reason that a minimal risk threshold was thought to be warranted was, one, to speed IRB review procedures, and secondly, to protect human research subjects while also allowing some research that didn't necessarily require full full informed consent. And by the end of my comments, I hope you'll understand when that is. And by the way, I'm going to try to keep my comments brief because I think for those of you in the room, in a military environment, some of these issues have particular and peculiar meanings to you, and I think it would be worthwhile to hear your thoughts. Well, before talking about minimal risk, I do want to just mention that there is a threshold below minimal risk, and that is, most of you are aware that there are some research activities that are exempt entirely from the requirement for prospective IRB review and approval. In fact, there are 6 categories of research that, although they involve human subjects, are exempt from the requirement of prospective IRB review and approval. And the general rationale behind the 6 categories is that although the research involves human subjects, it does not expose them to physical, social, or psychological risks, and therefore the protection afforded by full IRB review and approval is not necessary. Although you may choose to review research which is otherwise exempt in an IRB, it's not necessary to do so. And the only reason I raise this issue is because the OPRR in 1995 issued an OPRR report that stated that institutions ought to have procedures in place for making determinations about research that is exempt from IRB review and approval. That is, that investigators themselves should not be left independently to decide what research is exempt. And I think probably in most institutions, the IRB is the group that makes determinations of exemptions. I'd be interested in the comment period or the question period whether that's true. But at the NIH across the street, because we have so much research that's exempt from the requirement of IRB review and approval, our office, the Office of Human Subjects Research, makes determinations of exemptions. And the way we do this is, in fact, we reported our procedures in 1995 in the journal IRB, and I have a few reprints of that if any body's interested. But in that article, we give a copy of the form that we use. What we do is we require investigators who are asking for an exemption, that is, they make the preliminary determination that the research they want to do is exempt. That is, they don't write up a protocol and send it to the IRB, but they think, based on their knowledge and understanding, that the research is exempt from IRB review and approval. They fill out our form, which is in fact on our home page, and then they send it in to the office, and we review the contents of the form, and if necessary, we call the investigator and talk to him or her about the research, and then we respond in writing as to whether or not the research is exempt or not. We found this to be a very effective way to keep track of the research that's being done. In fact, in the article that we published, we reported from 1992 to 1995, 200 plus exemptions, and since 1995, we've implemented at the NIH a computer-based training program on the protection of human subjects. And so because our researchers, of which there are about 4,500 or so, are more educated now, the number of exemptions has jumped. And I think we have now since 1992, about 500 exemptions. And so we felt that even though we do have 14 IRBs on the campus, that 500 exemptions is a pretty heavy load to ask already busy IRBs to judge. And so our office has made those determinations, and we think the system works pretty well, but I'd be interested in knowing what systems you all have set up. Well, the general definition of minimal risk, Dr. McCarthy alluded to, and I'll just read it to you because I think hearing it once is important. Minimal risk means that the probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life or during the performance of routine physical or psychological examinations or tests. And I think Dr. McCarthy is very right to say that the interpretation of this definition and the application of this definition are very much dependent on the IRB's knowledge, first of all, that there is a definition of minimal risk, and also in applying it in a common sense and sensible way and exercising good judgment. And the reason why I say IRB should know about the definition is that I think that busy IRBs often do forget that there is a definition, and many IRBs, the members of IRBs, do develop their own intuitive notion of what minimal risk is. And I think Dr. McCarthy alluded to that researchers, pediatric researchers or oncological researchers, in light of their daily professional experience, often interpret their intuitive notion of minimal risk may be much different from a layperson's definition. And so the first thing I think that I would like to say is that all IRB members need to know that there is a regulatory definition of minimal risk and realize that it is not so easy to interpret, but you've got to try. But I think the idea that there is a definition that forms the foundation for the IRB's discussions based on minimal risk is extremely important. And I don't know how you all educate your IRB members, and especially new IRB members, but if you have many IRBs or busy IRBs and you're rotating members on and off, sometimes it is hard to educate them on many issues, and this is one that I think may tend to get lost through the cracks, other than just handing someone a copy of the regulations and say, read them, which is pretty darn boring. I think there need to be some focused attention to a variety of issues in the regulations, and the definition of minimal risk is certainly one of them. Well, why is it important for an IRB to know about the definition of minimal risk? Well, it's very important, and one reason it's important, as I alluded to a minute ago, is that the review process can be changed if a research protocol is determined to be minimal risk. And the first decision that a chair can make about the review process of minimal risk research is to review it according to an expedited review process. Now, not all institutions have these procedures, I've been told, but I think most IRBs do. And as you know, the notion of expedited review, the expedited review procedure may be carried out when research is determined to be minimal risk and it is listed on the list at the end of the regulations, the list of procedures which can be reviewed by minimal risk. And I assume most of you know that list. It's actually the last page or attached to the regulations. And the criteria for expedited review is that the chair has to determine that both exist, that the research is minimal risk and also it's on the list. So conceivably, there could be research on the list that, in light of the experience of the subjects, is not interpreted to be minimal risk. So you need to meet both criteria. Dr. McCarthy's very familiar with this list, and maybe in the question and answer period he would comment on it. There's really nothing magic about this list. This list was formulated by people at the time the regulations were drafted and brought into being, and the procedures on this list, as you know, include the collection of urine and feces, some dental scraping, some physiologic monitoring such as electroencephalography and other procedures. In fact, I'm pretty sure it's November that the OPR will be organizing a conference or a group to discuss what else might appropriately go on this list. I think for a long time I've thought, why isn't magnetic resonance imaging on this list? Most all X-ray departments have very strict screening procedures so that people who have metal or shrapnel and that might be harmed by an MR are screened out. And it seems to me that smart, informed people can sit around and think about other procedures that could go on this list that would appropriately be considered minimal risk and also appropriate for review by the expedited procedure. At the NIH, we don't use expedited procedure very much, and I was actually a little surprised to hear that because in preparing for this discussion, I called our protocol tracking office and asked them how many protocols at the NIH have been reviewed and approved by expedited procedure, and they're very organized over there. She came over in a few hours with a computer printout and said that of the 902 protocols that are currently active at the NIH, most in the clinical center, only 60 have been approved by expedited review, so that's about 6.5%. Now, I don't think that's because there aren't more protocols that do meet the criteria for expedited review, that is, they're minimal risk and they're also on the list. But I think that has to do with a conservative approach that our IRB chairs tend to take. I think they generally tend to see that research benefits from a review by the entire convened committee of the IRB. So it would be interesting to see in a review of those 900 protocols which ones also might be reviewable under expedited review, but the chair, for whatever reasons, chooses to have the entire committee review it. I'd be interested to hear in the comment period how many protocols your IRBs review by expedited procedure. Certainly it's unusual in our institution. As you know, the chair can either perform the expedited review himself or herself, or ask a more knowledgeable or experienced member or members of the IRB to perform that expedited review. And there is a requirement that the procedures be in place for the IRB to keep all of its members informed of what research is reviewed by the expedited review procedure. At the NIH, generally, what happens is the chair will put on the agenda any research he or she has reviewed and approved by expedited review in the interim since the last meeting, and that goes into the records, to the minutes of the IRB, and that seems to work pretty well. Well, the next important thing that can happen if research is determined to be minimal risk is that some or all of the requirements for informed consent may be waived. Informed consent can be waived entirely, or some of the requirements can be altered. And this is a very, very difficult area, I think, and Dr. McCarthy really is an expert in this area. He was very much involved in the discussions of waiving informed consent in the context of emergency research, which many of you are familiar with. We can talk a little bit about that, but the requirements for waiving informed consent, or waiving the informed consent process entirely, or altering some of the requirements, is a very challenging area. And again, I think many IRBs don't know that they have this authority. So I think another caveat here would be to make sure that if you do review research in which the informed consent can be waived or some of the requirements altered, that your IRB really knows and understands at least the words on the page, because the words on the page are pretty clear. It's when you try to apply those words to a particular situation that is very challenging. I'll just briefly review those. I think most of you are familiar. In order to waive or alter some of the requirements of informed consent, the research must involve no more than minimal risk to the subjects. The waiver or alteration will not adversely affect the rights and welfare of the human subjects. The research could not practically be carried out without the waiver or alteration. And whenever appropriate, the subjects will be provided with additional information after participation. Now, this last requirement, I think, and Dr. McCarthy can correct me if I'm not right, stemmed from the use of these criteria in deception research, that if a research subject is not going to be informed of all of the aspects related to research participation because telling the subject will impair or impede the research design, at least after the study is completed, the subject should be debriefed, told about what the study was about and why information might have been withheld. Well, these 4 criteria are pretty tough to apply, and for those of you who were involved in some of the discussions in emergency research, that is research that takes place in an emergency context, either in an emergency room or in acute trauma, or many studies involving comatose or neurologically injured people, much research conducted, well, all research conducted over the last 15 or so years in the emergency context was generally justified on the basis that it met these 4 criteria. And I don't want to dwell on that now. We might discuss some later. But basically, if you are going to use these criteria, my advice to you is that your minutes document that you have for any particular research study documented each of these 4 criteria. And I think particularly when waiving informed consent or when allowing deception in research, the IRB must be particularly vigilant that it's exercising good judgment and that its decisions can hold up to public scrutiny. And I don't know within the DOD whether you're under the same glare of the public scrutiny. My guess is you may be even more than we are at the NIH. But I think an IRB that is doing its job and is applying to the best of its judgment the requirements and the regulations, to some degree it ought to welcome scrutiny, or at least not discourage scrutiny. And so when applying these more difficult kinds of definitions to research, I think documenting in the minutes, which can be, at least at the NIH, obtained through the Freedom of Information Act, documenting in your minutes that you did discuss each of these issues and you have documented them for public scrutiny is a very good strategy. And just before leaving this topic of waiving informed consent, the 4 criteria are still applicable to the conduct of research in emergency medicine. That is, the FDA has generated new regulations that allow for the waiver of research, the waiver of informed consent in emergency research. But if an IRB determines that in an emergency research study, the 4 criteria that I just mentioned to you do apply, an IRB may still approve research in the emergency context under these 4 criteria. That was unclear to me. One of my colleagues from a shock trauma center called and explained a situation in which they felt that an emergency room study clearly fit within the context of minimal risk definition. And I agreed with them, even if you took the more narrow definition of minimal risk that OPR has tended to take over the last 2 years or so, in which they had been applying the comparing the probability and magnitude of risk to the daily lives of healthy people, not to the subject's life. And even if you took that strict definition, we both felt that the study he was describing fell under the criteria of waiving informed consent. So that'll save an IRB an awful lot of trouble, because if you go through the new FDA procedures, a number of new requirements, including community consultation, Data Safety and Monitoring Board, a number of additional protections are required in the new FDA regulations, which don't make sense at all in the context of a study that he was describing to me. That is, it just doesn't make common sense to offer those protections in a situation that he described to me. Just quickly to remind you that minimal risk is also relevant in the requirements for documenting informed consent. That is, when research presents no more than minimal risk to subjects, the IRB may waive the requirement for the investigator to obtain a signed consent form for some or all subjects, and that's 46.117. I'm not going to dwell on that, but just remember, and this may be particularly important in a military research environment. Some of the previous comments suggested that documenting informed consent had been a particular problem during the Persian War, the Gulf War. So remember that if research does fall into a category of minimal risk, certain documentation requirements are allowable if an IRB's judgment considers them appropriate. Just a comment on research involving children. As most of you know, the definition of minimal risk is a very pivotal one in reviewing research involving children, and the common rule does not include subpart D of the regulations, which is not a part of the common rule as I understand it, but I would be interested in hearing in the comments whether all of you, I assume, have adopted the requirements in subpart D of the regulations and are giving careful consideration to research involving children. The risk threshold for children has to do with not only minimal risk, but also whether or not there is prospect of direct benefit to the child, to the individual subject. And as you know, when an IRB determines research involving children to be minimal risk, it then turns its attention to assuring that appropriate procedures are in place for soliciting the assent of the child and the permission of the parent. That's category 1 of allowable research involving children. The category 2, as you know, is research involving greater than minimal risk, but presenting the prospect of direct benefit to the individual child subject. And I have had an interest in this area, this category of research for some time, because it is this category that investigators and IRBs use to justify drug treatment trials, and particularly phase 1 cancer treatment trials in children. And the subtlety of the statement presenting the prospect of direct benefit to individual child subjects is a challenge, I think, in light of phase 1 clinical trials, which may offer more prospect of direct benefit to children than adults at times, but I think that's a very challenging area in trying to figure out what is the chance of direct benefit to the individual child in phase 1 clinical trials, which, as you know, is often the first administration of the drug, if not to a human, certainly to children. That is, a phase 1 drug may have been used in an adult or maybe not. So this is the first administration of the drug, at least to children and maybe to humans, if the drug is being used for a tumor or a cancer that is particularly peculiar to children and hasn't been used in adults. I think the most vexing of all the categories is the third one, and I'm not going to dwell on it, but I do want you to rekindle your thinking on it, and that is research involving greater than minimal risk to children and no prospect of direct benefit to the individual subjects, but likely to yield generalizable knowledge about the subject's disorder or condition. And for those of you who have grappled with this category, you're well aware of its difficulties. It has been discussed or debated for many years whether this category is relevant to research involving healthy children, or whether it applies only to children who have a disease or a condition, meaning some pathological process. And it has been used, and in fact, the NIH had been severely criticized on using this category of research for allowing the administration of growth hormone to normal children children who had a short stature and were being given growth hormone to help them grow. And there was much criticism that short stature is not a disorder or a condition, that short people do just fine, and using this third category to justify the administration of a compound like growth hormone that had at that time some very small risk of a disease called Jakob-Creutzfeldt disease, which is a very bad disease, but that is a possible contaminant in growth hormone, that was ethically impermissible to do so. Well, I just want to end saying that the risk-benefit analysis used in children's research is applicable to other potentially vulnerable research subjects. And I know Dr. McCarthy recently has been involved and is interested in the whole issue of vulnerable research subjects. Specifically, I'm interested in research subjects who have cognitive impairments and dementias. And Dr. McCarthy may mention this. Some of you may know that the state of Maryland is now drafting a statute that, if passed, would provide additional protections to people who they call actually decisionally impaired. But they have an operational definition of that in the statute. But certainly people with dementia would be involved, would be under this definition, and other people with delirium, anything that causes the person unable to give valid informed consent. And the Maryland statute is based in some ways on the policy that we've had over at the NIH for a number of years, for about 10 years now, which, like the children's regulations, puts additional protections in place, specific additional protections in place for vulnerable subjects, those cognitively impaired subjects, based on the risk of the research and the degree of their cognitive impairment. So this notion of minimal risk and the prospect of direct benefit to individual subjects, while it's specifically in place now in Subpart D for the children's regs, are applicable to other potentially vulnerable research subjects. So I think I'll end there, and I think we should have a good discussion. Thank you.
There are microphones that are up in both of the aisles, and if you have chosen to submit your questions on your colored cards, just hold them up and put them into the end of the row, and somebody will come by and get them. Sir.
Since the subject has been broached, my personal preference on Air Force aircraft is to exit while in flight. I've met the bus driver. I'll get off before the next stop. I sit on the Surgeon General's HSRB, and it's often been a problem with, I say often, but it's in a small number of protocols that have supposedly been peer or scientific reviewed, that the science, in our opinion, is of questionable value. And my question is any level of risk acceptable if, in the opinion of the IRB, the validity or merit of the study is questionable?
If the study is, let me take a slightly different case than you presented, where it is clear that the study is not likely to yield sound scientific results, then it is ethically wrong in every such case to expose subjects even to very slight risks in order to carry out a study that can yield no valuable new knowledge. Your case is where the science is questionable, and there I think the IRB needs to make a determination through interviewing the principal investigator, bringing in outside consultants, and finally reaching a decision: is this valid science or not? If it is, then all the rules apply and you may go ahead. If it is not, in the best judgment of the IRB, with whatever consultation it needs in order to reach that judgment, if it is not sound science, then it is unethical to involve subjects in the study, and it must be either modified so that it becomes scientifically acceptable, or it must be rejected or overturned. Is that responsible to your question?
Yes, sir.
I would just say it's a real problem that IRBs face, and I know we face this across the street. It is really best if there is a relatively strict pre-IRB scientific review that is good. I mean, it sounds as if there is a prior scientific review, but if you question it, of course, that's a problem. But many institutions do have a scientific review committee that reviews the science and makes sure that the statistical the number of subjects is appropriate, and that the primary objective of the study can be met, and that the primary objective of the study, well, whether they decide whether it's important or not is probably too much. My guess is that they don't decide whether it's important, but that it is clearly stated and it can be learned from the study. But it would be really interesting to know how many studies get done that either don't get finished or aren't published. And my guess is that for all the studies that are completed, the number that actually yield results that are disseminated in any way may be pretty small. It'd be interesting to know as throughout the country whether your problem is a generic one, but my guess is it is, and that IRBs spend a lot of time on science and at the end run out of time to deal with the issues of protection of human subjects, which is a real shame because they should not have to spend their time dealing with the details of the scientific design. That takes them away from their primary mandate, protect human subjects. But of course, Dr. McCarthy is exactly right. If no knowledge can be determined from the study, then there is no ethically justifiable reason for exposing subjects to risk. And it's not only those subjects, it has to do with the integrity of the research enterprise as well. That is, you're asking subjects perhaps to even undergo inconvenience. There may be no risks. There may be only inconveniences, but as an enterprise, an intellectual enterprise, and a scientific enterprise that's funded by public funds, the enterprise itself suffers if research is done that cannot be completed or doesn't yield information.
I'd just like to amplify on that a little bit. One of the tasks of the IRB is to assess both benefits and risks, and the benefits must outweigh the risk. In a study that is truly flawed so that there can be no benefit either to the subjects or to society as a whole, then of course, even if the risks are very small, there are no benefits to offset the taking of those risks. And it is for that reason that it is unethical, because the risks outweigh the benefits and therefore call for disapproval of the study. Statistics were gathered some years ago. I think they're probably still fairly relevant. Only 1 or 2% of projects submitted to IRBs are disapproved, but something close to 50% of projects submitted to IRBs are modified. And those modifications, in many cases, turn on the science, and therefore, investigators are gradually learning that IRBs help the quality of the science as well as maintain the ethics of the entire enterprise. So the IRBs serve a very important scientific as well as ethical function.
But Troy, do you think that's because scientifically flawed protocols come to the IRB, and if there was a way to decrease the scientific flaws, then the IRBs would be able to focus more directly on the issues of human subjects protection.
I don't have any data, but my experience suggests to me that in most of our major research centers, there is a separate scientific review that is very rigorous, and that takes the onus off the IRB to do that. But in smaller institutions with perhaps less funds and less personnel, oftentimes the scientific review as well as the ethics review is left to the IRB. So it depends on how things are handled in your particular institution, whether or not that onus falls on the IRB. But if it does, it is an additional burden, and the IRB cannot duck it because it must do a risk-benefit assessment, and the benefits must be soundly established in the science. Otherwise, it is unethical to move forward in the research. Is that responsive, Ellison?
Sir?
One of the most vexatious things that we have to deal with in minimal risk protocols, and something that either presented or expedited categories, is in the study of existing specimens and records, the need to maintain subject anonymity in those records. Oftentimes, an investigator will come to us and say, I have some pathology and specimens, and I want to correlate what's in the record. It means that the individual has to be able to identify subjects from the record of the pathology specimen, and wants that to go under exempt review because it just studies the existing records and promises not to identify subjects from the papers published. We often say that that probably is expedited because of the need to identify subjects by investigators. Can you help on that?
Let me begin. I think Dr. Wickman can perhaps give you some concrete examples. But first of all, in our discussions with IRBs, we found that many investigators, simply because of their training and thoroughness, like to keep identifiers even when they're not necessary to the research design. That should be discouraged because it places the subjects at a small but identifiable risk if identifiers, whether coded or not, are kept in association with the data or the specimens or the samples from either past or existing kinds of places where data or specimens are retained. If it is necessary for the research to keep identifiers, then the IRB needs to look at it. In most cases, the risks are small, but they're not vanishing. And consequently, the IRB may have only one issue to look at, namely, have proper safeguards been put in place to code the data, to safeguard the data, to protect the identity and the privacy and confidentiality of the subjects. And that's why it's placed in expedited review, because investigators tend to think of this research as risk-free, whereas we all know now with specimens relating to AIDS, specimens relating to genetic structure, specimens relating to sexually transmitted diseases, data of that sort can be very explosive. And so utmost effort to protect the confidentiality of that data must be in place, and it is the IRB's responsibility to see that that's the case. That's why expedited review is required if there are identifiers, even though they are coded.
Well, this is a really difficult area, increasingly so. The National Bioethics Advisory Commission actually has a subcommittee, a genetics subcommittee that's looking specifically at this issue of the use of data or samples from the standpoint of genetic research. And my guess is they're going to come out on this in a pretty restrictive fashion. That is, that if there are any identifiers and anyone could identify an individual subject anywhere, then that's considered a code or an identifier. And the research, the paper that we published in IRB that I mentioned on our exempt research procedures might be interesting to you. Actually, we're probably more lenient at the NIH than we should be. That is, the scenario that we have, the situation we have, is that often samples, human samples or data, but more often samples, are being sent from someone in Sweden to an investigator at the NIH, and it comes to our NIH investigator with a code. He has no way of knowing, being able to break the code, but conceivably the person who sent it to him could. And in the past, up until recently, and we are now in the process of coming up with a new policy, if the NIH investigator, if neither the NIH investigator nor the investigator who sent him the sample, in this case a Swedish investigator, intended to in any way break the code, then we would allow an exemption. That is, if it was sent with the code, but there was neither collaborator intended, regardless of the results of the research, intended to break the code and identify individual samples, we had exempted that in the past. Now, the growing trend towards that's a trust mechanism. Somebody says they're not going to do something, they can still do it. But I think the whole process is becoming much more stringent, and we're in the process now of coming up with a new policy at the NIH. And what we're going to do is there's going to be a process for anonymizing samples, an independent third party that would anonymize samples. And I think generally in your scenario, Dr. Dutka, if you are unsure, then it's best, if not to expedite, you can always ask the entire IRB to look at it. That's generally what would probably happen at the NIH. It wouldn't be either exempt or expedited. It might be that OHSR determines the research to not be exempt, and therefore the full board, then the investigator would be told it's not exempt and he would need to write a protocol. Or, the protocol could be very small. It might be a page or two saying, I'm going to be receiving samples from a Swedish investigator. This is what we're going to do. This is how we would not break the code, or we would break the code, and then the IRB would review that. But it's very difficult, and all I can say is that at least we have a procedure at the NIH, and we're willing to have people criticize it. Do other people have formal procedures for exempting research, written procedures, or is it more for determining exempt research? Well, informal procedures may be good enough.
I think with the Human Genome Project advancing as rapidly as it is, this question of confidentiality is going to arise with a poignancy we have not seen in the past, because the data may apply not only to the subject who provided the specimen, but to a whole family or to a whole community. And consequently, maintenance of the confidentiality becomes all the more critical in those cases.
Please.
The Indian Health Service has a policy not only of that it must be anonymous by individual tickets to be exempt, very strict on that, but also that the racial or ethnic identity of observers also not be retained in the specimen, so that you cannot make conclusions about the community of the individual, but have to be totally anonymous about either individual or environment.
To be exempt?
To be
Do you
exempt.
exempt?
Otherwise, we do it by expedited protocol.
No hands, so I'd take the moderator's prerogative and ask a sort of a two-part question. And one of it has to do with the issue, which in the 12-plus years I've been on the IRB over at Walter Reed has repetitively come up in terms of pediatric research and the issue about benefit, and it's now been extended to other populations. Now, one of the arguments or discussions that recurrently is used is that, is there an inherent benefit in being involved in clinical research? Can you argue that to have somebody involved in a well-organized protocol with all of the intrinsic follow-up and advantages that can go with being involved in that, does that in and of itself a benefit, and therefore, when weighed against the risk in this population, is a direct benefit and therefore would therefore be allowable for certain pediatric populations and other vulnerable populations? And I can tell you that this discussion probably comes up about every 2 years, and that the pediatric researchers make a very strong case for that, that there's actually a benefit beyond what we consider to be standard of care. And I'd be interested in your opinion with that particular population and to other populations where you may extend that now, the HIV population and certain other populations where just being involved in the research itself may be considered to be enough of a benefit to overcome even a minimal risk situation.
You've clearly put your finger on a very controversial issue, and I think the number of IRBs that count as a benefit simply being involved in the research is growing. I also sit on 4 data and safety monitoring boards, each of which has seen consent documents submitted to it by the local IRB, and each of which has gone back to the IRB and said that doesn't count as a benefit simply to be involved in the research. Otherwise, any research would carry with it a certain experiential kind of benefit, and that's not what was intended in the regulations. I think that generally speaking, an IRB should be very chary of simply saying, well, there are no benefits other than the experience of being in research, and that's good for anybody, especially for a child to learn something about how science works and so on. There are other ways of providing that kind of information by including a child or any subject in research. And so my own opinion would be, although the regulations do not specifically address this point, my own opinion would be that that ought not to count as a research benefit and not be put into the equation of risk-benefit analysis. It probably will bear further scrutiny. Many will argue that this truly carries with it some lifetime benefit. I have yet to be persuaded.
Let me clarify something. I really, in the arguments that I've been a party to, it isn't necessarily the experience of being in research. It's the fact that if you're in a pediatric oncology protocol, that the mechanisms, the studies, the testing, the follow-up that is inherently built into the stringent nature of that type of protocol, that there is a benefit, direct benefit in terms of the care that the child is going to get, rather than the experience of being a part of research, which I would concur with your original opinion. But I'm talking about the benefit in terms of care by being a part of that type of healthcare delivery system, if you will, that is now a part of these very aggressive clinical protocols.
Go ahead. That argument has been made not only by the pediatric community, but by the HIV-infected community as well. When they said, in fact, and certainly with a good deal of merit, in the early days, particularly of the AIDS epidemic, that they could get far better care in the context of a research protocol treated by knowledgeable people than from ordinary physicians who perhaps did not know a whole lot about AIDS or HIV, and could not provide the same degree of follow-up or care for their disease. The IRBs tended to accept that argument in the HIV case. I suppose it can be extended to the pediatric community as well. The problem I see is a social one, namely that it is an under-the-table way of turning research into healthcare delivery, and instead, I think our society has to provide better healthcare delivery so that the research community is not expected to play the double role of providing research and excellent care. So I think this should be discouraged. Nevertheless, I'm reluctant to say never.
I'd just like to say 3 short things. First, Dr. Lasagna is going to be talking later about the potential conflict between physicians being researchers. And I think pediatricians making this determination does, I think, when you hear pediatric oncologists and other physicians making statements about benefits to research, I think you do need to take it with a grain of salt and realize that the same people who are delivering medical care are often also delivering research care, and that while no physician I have ever met has ever acknowledged the potential conflict of there's some kind of block that we as physicians have to suggest that we could have a conflict of interest in our medical care delivery and our research activities. Clearly, there are conflicts, and I often wonder if our unwillingness to admit them and talk about them may be perpetuating some of the thinking that, in fact, there are conflicts. But I think maybe Dr. Lasagna might bring up some of those points. The second one is that it would be very interesting to know if this discussion about research participation as a benefit is uniquely American. I don't know that, but it would be a lot easier for me to buy that argument if everyone in this country had routine medical care. And I don't know, free medical care. I don't know about your institutions, but when we've been seeing AIDS patients since the day I walked in the door in 1982, I've been seeing AIDS patients, and many of the children who came for AIDS protocols were poor children with no medical care. And certainly the benefit to them being in a research protocol is medical care at the NIH or nothing. And I had always felt very uncomfortable about that choice. If there was something in between, that if they didn't participate in a protocol, they would get the best medical care had to offer at that time, which of course probably wasn't as good in the early days of AIDS treatment as in research centers. The third thing is that this idea of research as a benefit reflects, I think, the change that our society has gone through in looking at research. That is, when the regulations were formulated, and they still are called the protection of human subjects, research subjects were determined to require pretty extensive protection from researchers who had taken liberties and hurt research subjects for years before. And since 1981, IRBs have really done a pretty good job. And there have really not been many research disasters, certainly nothing of the magnitude that came previously, Tuskegee and Willowbrook and other notorious examples that we always use. And so, and with the AIDS epidemic, where AIDS activists felt that the best medical care was research care, the trend has been towards looking at research care as medical care. And on one hand, that's okay, but I think in terms of the protection of human subjects, it can be very dangerous, and we ought not be too willing to blend medical care and research care, and we ought to keep clear distinctions about the two as best we can.
Sir?
Make a comment on the connection between true informed consent and the incentives that offer programs. For example, in many overseas research, field of license may not seem like a lot, but government incentive to people, and even in minimal risk, they may volunteer merely because of the incentive. Can you make a comment on that?
Merely because of what?
For example, for filling in life
I was involved in the design of a study of a dietary supplement in a remote section of China, where it was felt that a dietary supplement might diminish or remove a serious disease that infected the population. Two villages roughly identical in size and culture were chosen. One was given the dietary supplement and the other not, in order to determine the effects of the dietary supplement. It was clear that the village that was selected as the active participants, not the passive ones in the research, was to receive better food than the other village. The IRB turned that down and revised the protocol in such a way that both villages received better food in the course of the study, even though only one received the dietary supplement until the results were established. That is much more costly. It is difficult. But part of our responsibility in carrying out science in other countries is to carry it out in an ethical way. I recall very clearly the statement of the Assistant Secretary for Health of an African nation, who said to me, "Do not lower your standards in our country even though we are a third world country. If you do, we will always remain ethically a third world country. We would like to become first world ethicists as well as scientists." So it's more costly to provide for these kinds of things in research in foreign settings. It is extraordinarily difficult. Sometimes we cannot do it as well as we could do it here. Then an additional judgment has to be made. Is it better for the whole population to do this at all, even though there is an element of unfairness in the situation, or not to do it? In most cases, I think we would answer affirmatively, it's better to do it as best we can, even though we cannot meet to the letter every requirement in the regulations, than not to do it at all. So that would be my view, but I would argue that in many cases, with a little extra effort, we can bring even research in third world countries up to the standards that we would require here. Not in every case, and in those cases I would still go ahead unless the harms are extraordinarily large. Is that responsive?
Yes, I think the point really being that we're making an effort to be operating our standards are sometimes in those cases higher than they would be in some of the third world countries. And we're making every effort to recruit volunteers. And the one thing is trying to meet the true informed consent.
Exactly.
It's very difficult, and we're often incentive that doesn't seem like much, but turns out to be a real incentive with people. And I guess as a volunteer for study, where they might not only volunteer.
Even in this country, it's often very difficult not to build incentives in that might skew the consent process. More difficult in foreign countries. About all I can say is do the very best that you can. And that may fall short of an ideal, but it nevertheless raises the ethical consciousness in those countries and moves them in the direction of a sound ethical system.
The other thing I would say is this area is where one area where I think our system needs improvement. Many areas do, but we do quite a bit of collaborative international research at the NIH, and one of the requirements, as you well know, is that there be a local on-site IRB to review the research. And in the best of all possible worlds, an IRB in the United States, that's usually the IRB of the funding institution, and an IRB on site ought to be colleagues and collaborators in improving the protection of human subjects. Of course, it depends on what the IRB on site knows and understands about ethical requirements, not just ours, but also their cultural requirements. In some instances, our regulatory requirements ought to be waived because they do not fit the environment and the culture and the other local requirements of the research. And this is an area, I think, that if anyone got interested in trying to set up a system of education and communication between IRBs, they could make a huge impact, because while NIH reviews a lot of these protocols here, we don't have access to the thinking of the on-site IRB, and we don't even know what they're working from. They're supposedly working from the federal regulations or the Helsinki Declaration or the Nuremberg Code, but actually what process takes place is very important. And in fact, they know the on-site people much better than anyone else. So that's an area for someone to set up a business to help educate IRBs.
Let me just say that session 4 at 1:15 today with Drs. Albert and Levine is going to discuss that issue in somewhat greater detail. We have time for one last question, sir.
Yes, I was wondering whether the panel would be interested in making comments dealing with the scenario of human subjects research among a experimental subject population that are professional subjects, volunteer for the environment, knowing that intrinsically it's a high-risk environment, but these studies certainly can have a high risk of injury, even the probability of that injury is low. Two examples of those special populations, just to share with you the perspective that I'm addressing, would be test pilots or experimental divers who are participating in studies to try to investigate better decompression procedures, etc. And I would be interested in the comments that you might make relative to the ethics of conducting those studies and the protections of the rights of those subjects given their special status.
Let me first take a shot at it. This is not an area where I have any special expertise. I suspect that first, just a way of following up on your question, it would be useful to talk to the people at NASA, because they have faced this problem perhaps more than other agencies that I know anyway, and have worked out their own set of regulations for experiments in which astronauts whose job it is to fly into outer space nevertheless have the option of participating in a variety of experiments carried out in the course of their duty. And so I think those regulations pertaining to NASA might be useful to you in the context of diving in high-pressure situations or other sorts of risky research that requires a kind of special population of subjects. In general, I think the importance here is to create an environment in which potential subjects carefully consider the risks and are somehow removed as best you can educationally from a kind of macho environment that suggests unless you do this, you're not going to be eligible for advancement or promotion or decoration or whatever other kinds of rewards that might be underlying motives for taking extraordinary risks. The setting in which informed consent is obtained in those situations becomes extraordinarily important. And those obtaining the consent or discussing the issues with them in the consent process need to try to minimize external kinds of pressures to the maximum extent possible. That's about all I can offer you from my own knowledge. and I recognize it as a serious problem, and I haven't really answered it except peripherally. But I think if you talk to NASA, you can perhaps get a little more light on a very difficult kind of issue. Allison, did you want to?
Well, thank you very much, and we will reconvene at 10:30.